we don't have
Yeah.
we don't have the polling questions
Okay.
for this. Yeah.
Okay.
Mhm. Mhm.
So
No
we
problem.
can start with the presentation from Dr. Tichinda.
I- I- uh,
Yes, so I'm working on sharing my screen right now, and
All right.
You are a co-host. Is the share screen button? There you go. Perfect.
okay, can you all see my screen?
yes.
Excellent, so I can proceed then. Can you hear me?
Yes, I can hear you, and the screen is perfect.
Yes, we
Jachinda.
can hear
I
you.
see it as in presenter view.
Okay, great. So, as mentioned already, I'm Chinda. I'm an internist here at the Bingo Baptist Hospital in Cameroon. And Dr. Toomey had mentioned about the possibility of presenting some of the cases from Bingo, so we chose this one. He also talked about the possibility of having one of our residents present the case so that I can just do treatment and the pathology itself. But unfortunately, our residents are right now involved in their end of year evaluations. So they could not participate today. So what we opted to do is that I was going to go through the case really briefly and also have a really brief presentation on the management as well as the pathology that we suspected for her. So the case we chose was that of a 23-year-old female student from Cameroon. She was referred to the internal medicine department of Bingo Baptist Hospital by the ENT team. So she had presented there with what they described as dysphagia. And after doing an examination of the oral cavity, the posterior nasal space, the pharynx, and the larynx with a flexible scope, they decided to refer her to the internal medicine department for further assessment. So she had reported progressive difficulties swallowing over the preceding 4 years. This occurred to solids only and was initially only noted during deglutition of large and hard food boluses. But she gradually progressed to have the dysphagia even with solid, semi-solid meals like pap. So when we met her for the first time, her dysphagia was scored at 2, and this is the Melo-Pinkas dysphagia grading system, and the basal scoring for her was moderate severity. So she had no difficulties really initiating the swallowing process, but she had the impression of food quickly getting stuck in her neck. She had no nasal regurgitation, no cough during swallowing, no adenophagia, no dyspepsia, no dysphonia, and she equally denied any vomiting or diarrhea. She had reportedly lost some weight, but unfortunately, we could not quantify this. Her past medical history was remarkable for unexplained microcytic anemia, and this was first noticed 6 years back, that is 2 years before the onset of dysphagia. She had a prior assessment by a hematologist, and she brought records where we see documented very low MC levels, very low iron levels. And with that, her anemia was attributed to iron deficiency. The lowest hemoglobin recorded in her card was 4.9 grams per deciliter, but no obvious etiology was identified. So she had since required 3 whole blood transfusions. So she had received 3 units of whole blood over the past 4 years, and she had been on daily iron supplementation. So we started questioning her in an attempt to find out if there was a missed occasion or a missed opportunity to get actually an etiology to this iron deficiency anemia that she presented. But she denied any heavy menstrual bleeding or any abnormal blood loss, including GI. She had a regular, healthy diet that included iron-rich foods, and she denied geophagia, Now, I don't know how common this is in other sub-Saharan countries, but geophagia, which is a type of pica where the patient or the person voluntarily consumes earth, is actually a pretty big problem in Cameroon, and it commonly results in unexplained anemia. So, but this patient clearly denied the intake of any earth or calabar chop, as we usually call it here. She had no other chronic medical conditions, and her only routine medication was oral iron. So she was on no drugs that could result in decreased iron absorption, like omeprazole. She had no family history of anemia, no family history of malignancy, or even any relevant chronic condition in the family. Her physical examination, she was a pleasant young lady with a well-preserved general state. She had discrete pillar of the conjunctiva without jaundice. There were no palpable cervical nodes. The neck, the oral examination, the ear, they were all normal. She had a normal cardiorespiratory and abdominal examination as well. She had no skin changes, no nails changes, no joint abnormalities. So basically, apart from the discrete payload that was noted on physical examination, her exam was normal. And the absence of tachycardia, tachypnea, or even just orthostasis favored a more chronic nature to her anemia. So at this point, we identified two problems for this patient. She had the first problem was this chronic progressive structural proximal esophageal dysphagia. And then we considered, could she be having a proximal esophageal carcinoma? But she was pretty young and she barely had any risk factors to support this. We wondered about the possibility of a proximal esophageal stricture, maybe from a previously undisclosed caustic ingestion. Also wondered about the possibility of an esophageal web or eosinophilic esophagitis. Her second problem was the unexplained iron deficiency anemia. And again, we wondered about occult GI bleeding or a problem with iron absorption, or could she just be underestimating the heaviness of her menstrual flow? The very first evaluation modality that was attempted was an upper GI endoscopy, and it was initially carried out without sedation. And this turned out to be a problem because she became agitated just at the onset of the procedure, and we were forced to go blindly into her proximal esophagus. And once we did that, we quickly encountered significant resistance, and this caused severe pain and discomfort. So the procedure had to be interrupted without clearly visualizing what caused the resistance initially. Since she was reluctant to go for the endoscopy at that point again, we decided to go for a barium swallow x-ray, which was described as normal. Now I apologize because we didn't keep the images, but the internal medicine team and the radiology team thought the barium swallow, the barium esophagram was normal. A complete blood count confirmed the presence of anemia with a hemoglobin level of 7.1 grams per deciliter. It was severely microcytic. Her MCV was 53, a high RDW. White blood cells and platelet weren't too remarkable. A complete metabolic panel, this included liver, renal function, electrolytes, they were all normal. She had a guaiac fecal occult blood test that was negative on two separate occasions, and she had a negative H. pylori stool antigen test. We didn't repeat the iron studies primarily because she had financial constraints, but as mentioned before, she already had documentation of evidence of iron deficiency anemia on her prior assessment. So we asked and pleaded with her to return for an endoscopy, which she did. And this time around, we decided to perform it under sedation. And I attached a little video here. I hope the group will be able to visualize that. So I'm going to play it. I muted the video. But this is what we encountered about 16 centimeters in. She had this focal narrowing. I'll show some pictures later. She had this focal narrowing basically just after crossing the aerodigestive carrefour there. And we just could not pass that with our 9mm scope. There was significant resistance with that. And the present image again shows the same thing. She had this narrow, it's a little blurred, but I hope you can see. But there was this narrowing right there, and it's again just 16 centimeters in. And the subsequent image here shows basically the same thing, and you have this low flap here. Could it be a web, we wondered, or just a stricture? I'm curious to hear your comments about that. And what we did is the yellow thing you see passing down is a guide wire. So we passed down a guide wire through it and dilated it basically with bougie dilator Savary from 9 to 11 to 12.8 up till 15 millimeters. Now, balloon dilators at this point were not available, but as I'm going to mention subsequently, for proximal esophageal web, bougie dilator seems to be more recommended than balloon. And following this, really following the review, after performing that dilation, we went back for a review. And what we noticed was very minimal, well, minimal to no injury actually to the wall at the area where there was the narrowing. The subsequent stomach and duodenum could be assessed, and really we reached those effortlessly after the dilatation, and there were no additional abnormalities observed at the level of the wall. So following this bougie dilation, yes?
Yeah, I mean, we want to ask if there are any discussion. One question that had been asked was, during the initial endoscopy, were we able to pass smoothly, seamlessly into the esophagus? The initial one, without sedation. You didn't pass, you didn't reach to the upper esophageal sphincter also?
No, we seem to get blocked just at the level of the upper esophageal sphincter, actually. We couldn't pass that. And unfortunately, this was done blindly and under sedation, and not under sedation. So we had to just pull out quickly.
Okay. So
I have a question. Did you think this stricture was ulcerated? It's very pale in the images. Did you think it was ulcerated, or that the mucosa was intact in the stricture?
The mucosa looked actually intact. It did not look ulcerated at all. The mucosa looked just normal, though it looked a little bit pale, particularly at the most narrowed area, as we can see on this image. But the mucosa was just normal. And as I mentioned, when we went for the review, the area really had just minimal damage. You couldn't see significant mucosal abrasion from our dilatation, and the rest of the esophagus was just normal.
I guess we'd invite others who are on the call to unmute and ask questions of Chinda at this point before we keep going.
Yeah.
Zombo, I see you have some questions. Go for it.
Sensei.
Oh, yeah, I had a question about the barium. Yeah, how could the barium esophagram have been normal with this severe narrowing? Did the radiologist?
That is something we can't explain, really. I don't know how to explain that, but it was described as normal. We couldn't see any focal narrowing, any jet effect or anything. It just looked normal. So I don't know how to explain that, really.
We had a patient previously with upper esophageal sphincter narrowing. It's just below the upper esophageal sphincter, and the barium was initially normal. Maybe we have some difficulty with this. Akwi has raised hand. Akwi, please continue.
Yeah, I just wanted to, I guess, like make a few comments that I think would be kind of good for discussion. I don't know if you were planning to get into that. I think a case like this it'd be nice for people to kind of, what's going through your mind in terms of differential. But just the first quick question is, was there any weight loss?
So she did mention weight loss, but we could not quantify this, unfortunately. She had no previously recorded weights, but she mentioned weight loss, yes.
And this had been going on for 6 years, right?
Yeah, so 4 years for the dysphagia, but 6 years for the iron deficiency anemia.
Okay. So I think sort of like, a thought process, so the first thing is you have someone who's come in with dysphagia. A thing you mentioned in the history about, no coughing, et cetera. So some of the things you think about, all right, is this a Zenker? Is this a fistula? But then the no cough kind of rules that out. The duration of 6 years, weight loss is obviously significant. Iron deficiency anemia is significant. The weight loss sort of rules out a malignancy. And then the third point was, when you mentioned, microcytic anemia, I think in the setting of this young patient, you would want to think of plomavincin in the differential, especially when you find the web. I think an important point that I do want to make when it comes to endoscopy, I think if we have a patient we perform an endoscopy on, number one, we should never go blindly in the esophagus, because if you don't know what you're getting into, you could perforate and kill someone. So I think once you put a scope in, if you get resistance, you pull out and you stop. If you put a scope in, your patient is uncomfortable, we don't force them, we stop. So those are, I think, like very, very important points for us as gastroenterologists, endoscopists who are on the call, and the trainees to make a note of. So we should not force patients. We can always talk to them and bring them back. When a patient's agitated, we abort the procedure. And then in terms of the imaging, I definitely agree with the concerns of like, whoa, there's we see a stricture in endoscopy, but the imaging was normal. You can, and I think that's what Dr. Dessalin was alluding to, it being so proximal, it's possible that, it could have been read as a normal, normal study. So either they missed or either it was like so proximal that they could not necessarily visualize it. So I don't think a barium is 100%. And one has to ask, does barium really have a role when we have someone who's got dysphagia, weight loss, et cetera? Are we just wasting time and money? Could we just put those resources back into explaining the endoscopy better and repeating the endoscopy than, wasting the patient's time and money to perform a barium? I'm not opposed to it completely, but I'm just dropping these things for us to just sort of think about as we're evaluating patients. So none of this is like a criticism, but I just think these are points we should be thinking about as we go through these conversations and discussions. Thank you.
Thank you, Akui. Mzamo, can you tell us your observations here? Mzamo, Mabele. Yeah, so he raised the possibility of IDA with esophageal waves or stricture, which could be Plummer-Vinson syndrome. And he asked if you biopsy the stricture and history of atopy seems less likely in this scenario, but eosinophilic esophagitis. Other group members can also drop your differential diagnosis here. And I like the idea that had been presented by the Dr. Tichinda. He tried to rule as a possible cause of iron deficiency anemia. Dr. Tichinda, do you consider geophagia as a cause or as a symptom of iron deficiency anemia? I just want to clarify based on your description.
Now that is actually, first of all, we did not get a biopsy of the stricture or web that we encountered here, 16 centimeters down. And the question about geophagia and iron deficiency anemia, it's basically such a good question because when you read about it, it's almost like the chicken and egg paradox, right? Which one comes first? Because technically iron deficiency anemia can manifest or can trigger geophagia, but also geophagia can impair iron absorption and result in iron deficiency anemia. So which one causes which is really difficult to clearly state.
Okay.
Can I make one other quick? Can you maybe like define all those quote unquote phages for the for the audience, because some may not necessarily know the differences, dynaphagia, dysphagia, etc. And then another learning point for this is, I think you'd mentioned this is like in the upper, if you see a stricture such as this looks rather benign, but it's not necessarily clear if that erythema is from us, doing the endoscopy or whatever. But you can also see something such as this is seen distally, assuming there's like nothing around, it's not ulcerated, etc. One of your differentials would be like related to reflux. Could that stricture been sort of reflux induced? But maybe you could just define those phages for, because I think we do have some students on the call as well. Thank you.
Yes, so what we were basically talking about was geophagia, also called geophagy, just with a GY. And basically it's a type of pica. We know what pica is. Pica is the consumption of non-food stuff, but geophagia is primarily the consumption of earth material. So the most common one consumed in our context is kaolin clay. It's commonly called Calabar chalk. I don't know how it's called in other countries. But basically this is earth that is consumed, and that can impair our iron absorption. And usually pregnant women
take
it
on the
this.
chat box?
Oh, yeah.
Yeah.
Sure. So pregnant women in Cameroon take that a lot because it helps with nausea. But early infancy, like in my childhood, I consumed a lot of kaolin clay. The taste is just different, and somehow people like that. But we've been trying to counsel populations about not consuming that, but it's quite a problem in our context here.
It's a red soil-like appearance.
Tachinda, I was going to ask you about her severe microcytosis, refractory to iron therapy. Did she have a hemoglobin electrophoresis at any point? Is it even available where you are?
Yes, it is available. And the HB electrophoresis that we saw documented in her chart was AA. So it was normal. There was no evidence of sickle cell anemia. But I didn't think it was necessary to report that here, so maybe I should have.
No, that's
But it wasn't remarkable, yeah.
It's okay. Okay.
Okay, well, why don't you continue?
I think we can proceed, yeah.
Okay. So proceeding with her case, so following the bougie dilation of the stricture, the patient reported complete resolution of the dysphagia. So she was now rescored at 0, and she's been at 0 for 6 months now. She basically has no dysphagia anymore for 6 months since we dilated. She was maintained on oral supplementation of iron every other day, and she has no new or worsening symptoms since then. Her hemoglobin level, though, just before sending this case out, I decided to check it. And it is 8.6 grams per deciliter with an MCV of 68 femtoliters. So no more dysphagia, but she still has the iron deficiency anemia on 6 months of oral supplementation of iron. So she was asked to get testing for anti-tissue transglutaminase antibody. Our point here was to try to rule out celiac disease as a possible etiology of iron deficiency anemia, though to be honest, she had no other symptoms to support this. But she could not afford this. And you should note that it can only be done by a single laboratory in Cameroon, and it's about 370 kilometers away from our patient's residence. We also considered the possibility of just getting random biopsies of her small bowel. Again, this was declined by the patient for financial reasons. She still has no evidence of overt GI bleeding or abnormal blood loss from any other side. So I prepared just a brief discussion of what our thought was at this moment. So she had this triad of esophageal dysphagia. She had this proximal esophageal web/stricture, and she had this iron deficiency anemia. And as it was mentioned already, this led to the consideration of Plummer-Vinson syndrome in her. The financial limitations that she had affected her ability to clearly establish what could be causing the iron deficiency. And the bougie dilation, as mentioned already, resulted in a sustained clinical improvement for the past 6 months. So at this point, I personally had a few questions, one of which I'm going to answer when I briefly talk on Plummer-Vinson syndrome, if we have time for that later. But it was just how common is Plummer-Vinson syndrome in the African setting? But the other one was directed to the GI specialist here in this forum, the endoscopist as well. Like, which one do you recommend, bougie dilation or balloon for webs and stricture, and not necessarily proximal strictures? But also, how commonly do you recommend or consider random small bowel biopsies in an attempt to establish a diagnosis of celiac disease? And I think that was the end for the case that we had to present today.
I have a question.
Thank you, Chinda. That was really a great presentation. And I'd invite, is there any people on the call who haven't yet spoken up? If you'd like to make some comments about this case and the questions you have about it, we'd welcome that. And we'll circle back to Akui. Anybody want to unmute and make some comments or ask a question of to Chinda?
I just trying to supplement that it's good to consider celiac. It might cause iron deficiency anemia per se, but at ACG there was a presentation of celiac presenting as a sole manifestation of dysphagia. So it's good that to rule out such kind of conditions. Sometimes they may coexist, loosely coexist with Plummer-Vinson syndrome, but it might also be a cause of dysphagia.
Chinda, do you see celiac disease in Cameroon?
Well, we do suspect. There's only a single case that we were able to confirm with antibody testing, but most of the time we just do the food restriction, and then we see how they improve. So we do suspect, but we rarely confirm it. And again, it's because of the geographic and financial limitations.
But I think that's an important point, that it does occur uncommonly throughout sub-Saharan Africa. We certainly see it in Ethiopia, and it's an important thing to keep in mind. And your point about the antibody levels, I think, is a very important point also, because in our setting, villus atrophy on duodenal biopsy is not necessarily celiac disease. In fact, there's other things that are probably more common where we live that mimic celiac disease, such as small intestine bacterial overgrowth, common variable immunodeficiency. Both of these can result in a flat mucosa in the duodenum. So you're making a good point about being able to check the serologies. Kui, yes, please go ahead.
Thank you. I have two questions. The first one, and I may have missed this, what did the duodenal mucosa look like? And then the second question is, so you mentioned her anemia started 6 months ago. She has some weight loss. Has the conversation about a colonoscopy been brought up? And if yes or no, whatever the answer is, if no, why not? If yes, has it been done? Will it be done?
Yes, so we looked at the duodenal mucosa and it looked completely normal. It was just unremarkable at the level of the duodenum. We went as far down as D2, D3. Now, concerning her anemia, it actually started 6 years ago, and she's been transfused twice. She's had iron supplementation ever since. And we know the discussion about the colonoscopy has not been brought up. So maybe that can be considered when she returns. So no, we have not considered a colonoscopy yet, I must admit.
Kui, talk about that a bit more. Do you routinely recommend colonoscopy in young women with iron deficiency anemia?
Yes. So someone coming in, especially the history, where it's not, the main thing is, she menopausal or not. She's young, she's still bleeding, but if she doesn't endorse a history of bleeding, iron deficiency anemia, you'd want to think of colorectal cancer. The 6-year duration would make it very, very unlikely, that she's had CRC for 6 years. But I think to be comprehensive and just sort of, complete your discussion, you would want to consider that in your differential. So the answer is yes. I do iron deficiency anemia, weight loss, upper endoscopy, colonoscopy, rule out colorectal cancer, continue evaluation.
That's interesting, because many guidelines exclude young menstruating women from the recommendation to have a routine colonoscopy for iron deficiency. I mean, obviously there would be situations where, such as a family history or history of GI blood loss or evidence of occult blood in the stool, etc. Many situations where you would recommend it, but routinely, I find most guidelines exclude young menstruating women from that recommendation.
Yeah, and that's an excellent point. But I think something he mentioned that would make me do it is he said her periods are not heavy, because not all bleeding, menstruating women are walking around with iron deficiency anemia. So unless I missed something in the history, if the history, doesn't give good reason as to why someone has iron deficiency anemia, I would for sure go ahead and do a colonoscopy. Unless I missed it, is the patient having heavy menses? I thought you said they were not.
No, they were not. They were not really.
Yeah.
In an attempt to think colon, all we did really was guaiac blood testing twice. It's not 100% sensitive or specific. But yeah, we didn't consider colon, no. Yeah.
So I'm interested, for the endoscopists on the call, I'm interested to hear how you would approach this web and what you would do during the endoscopy. We already saw that a guide wire was passed across the web and that wire-guided dilators were used to dilate up to 14, I think. Jacinta, is that right? Up to 14 millimeters?
Yeah, up to 15 millimeters, actually.
15, excuse me. And it looked like it maybe just had a luminal diameter to start of 3 or 4 millimeters, maybe?
Yes, definitely less than 9. Yeah.
So, I'm really interested to hear the endoscopist on the call. How would you have approached this? And does the so-called rule of 3 matter with a web of the proximal esophagus or not? I'd really invite comments from the endoscopist on the call.
Sorry, for the length of the stricture, was it short focal stricture? How long was it in terms of length?
It seemed focal, like just a specific spot where you had the stricture and then everything else fine.
Okay. I mean, for me, I'm a hepatologist, so I don't routinely do savory dilation, but I do routinely do the balloon dilations, and especially for these focal short strictures. And I believe it goes up to 22, I'm going to say 22 millimeters for the stricture, but of course you would start, at the shorter. I would probably start for this one, like 13 to 15. As you did, but I would do a balloon dilatation. In our experience at Hopkins, I think there's higher rates of perforation. Sometimes the advanced endoscopists use fluoroscopy with it, but I don't think it's routinely necessarily needed. But just with the higher rates of perforation with savory, I usually do balloon dilatation if available.
That's a great comment. And in our setting, in Addis, balloon dilation is just too expensive because even if you take the best possible care of the balloon, it doesn't last that many cases. And to buy one for every case is just prohibitive. And so we use taper dilators, and that's where I think the barium swallow is so useful in our setting in a patient with a benign stricture that the scope won't pass, because it reassures us that the rest of the esophagus is normal and straight, and there's not a diverticulum in the esophagus or something else. And we can pass a guide wire and do the dilation over the wire without wondering where the tip of that wire is. So we also try and pass a large amount of wire past the stricture so that it's coiling in the stomach. If a large lengthy segment of wire won't pass, usually I like at least 50 centimeters of wire past the stricture, then so that it's coiling in the stomach, then we back off and say we need to take another approach. But I think where we don't have balloons, the barium turns out to be so helpful as a roadmap. But I'd love others to comment. Akui, would you dilate this all the way to 15 at one time? Is that okay with a web? What's your view?
So I used to like using the through the scope dilators because I like to watch it tear and see what I'm doing. But sometimes the challenge is the recurrence. And so it's strictures I generally have used the savories. And I don't always go back in. So some of the training I got from my teachers was, no, you don't need to go back in to see what you did. When you see blood on the savory, you come out, you're done. And the rule of 3s, I definitely used that in the setting of the through the scope dilators. The thing that I noted is, though, if there's no, that's one of the questions, if there's no resistance, do you actually count that measure? And I would say no. Then you don't start your rule of 3 at that moment. In other words, if you use an 8, 9, 10, but there's like absolutely no resistance, I don't think that would count. But I do use the rule of 3. So I do think either one works basically. The TTS or the savory. I think either one of those would be perfectly fine. The other concern is if you go in after the savory, there's, I want to hear what you think about that. This concern of, if you had like a micro tear, which would sort of be expected, but you would be putting air, if you use air in there and sort of worsening the situation, or even worsening the tear by going in to take a look. So it's like, if you see blood on your savory, just stop and be done. No need to go back in. So I guess that's another question for you. Do you go in if you use the savory to take a look?
So personally, I always look endoscopically after any dilation of the esophagus and take a careful look for any evidence of a perforation, because if I find a perforation, I'm going to take care of it right then. I'm going to put a fully covered stent if there's a significant stricture and clip or suture it in place, or I'm going to do something to address the tear. So I'd rather know than not know. So I always look. And so there are different views on this. And I think that as Chinda suggested, I think there may be some sub-evidence that bougie type dilator is more effective in webs, proximal webs and rings, although I think both are quite effective actually in my own experience. And I think your comment about rule of three is really important, to say you don't start counting until you meet resistance. And then it's really rule of three with regard to the tapered dilators, 3 progressive sizes. Many people, though, don't have all the dilators. They have every other one. And then what does the rule of three mean? Does it mean 3 of the dilators you have, or three of the dilators in the series? I think the original rule of three meant 3 millimeters once you start meeting resistance. So but the rule of three has never been actually well validated. So all of this is sort of received wisdom and expertise, I think.
Thank you. Hello.
Yes, to me.
Hello. To me, continue.
Yeah, we here in Bingo we always look. I thought it was is important to see what you have done. But in that case, you could appreciate the damage and how concerning it can be before you like send the patient for an X-ray to see if there is some perforation. And we always also try to suction the air from the belly, not to allow the maybe might further cause them aspiration or something like this. And I think like in 1 year we have like a complication in one patient, 2 at most, and we do a lot of dilation, more than 150 per year actually. So we always look after dilating a patient. Most of them are younger than this. But they are caused from caustic injection. So but we always look actually.
Well, and also in your setting, to me, the patient may have traveled a long way, and if you discharge them home with a missed perforation, they may never have the chance to come back. So I think a lot of this depends on your practice setting.
Yeah, exactly. We look, one of the reasons is that we look for that too, not to let them go home if we are concerned about it. Yeah.
Other comments, please. A lot of you have said nothing.
Other comments, like we have, for example, Dr. Jonas, if you can give us some summary from the Ethiopian data. Jonas Gadamu, can you speak now?
Hello, everyone.
Hello.
Good afternoon.
Good afternoon. How are you?
Fine. Thank you for inviting me to speak. So what we did is we did a retrospective cohort study in the capital city in Addis Ababa, and a multi-center study in 6 centers where the service is mainly being given. So a total of 126 cases were included. That is patients with benign esophageal stricture, the management outcome, and the factors associated with management outcome. So we have 126 total cases, and among those, the most common cause was corrosive injury, accounting 1/3 of the case, 33%, and it was followed by peptic stricture, which accounts around 27%. And the next is post-surgical anastomotic strictures was the third common cause of benign esophageal stricture. And the outcome, the clinical success, which defined by the, as you used, we use the Melo Pincus score and grade 0 or grade 1 as the clinical success, either no dysphagia or improvement, like tolerance of soft diet. Then it was achieved in 80% of the cases. So there was a good clinical success. And in particularly with your case, Kruman-Vincer syndrome or esophageal wave, we had 8 cases in the capital city in Ethiopia. So these cases, all cases, they have clinical success, 100% clinical success, and the mean dilation was 2. And regarding, I think in Sub-Saharan Africa, when I look in the studies, Kruman-Vincer syndrome was the most common cause of benign esophageal stricture in Senegal, among 101 cases. Otherwise, in the rest countries, corrosive is being the most common, like with some of the studies, mainly in the pediatric in Egypt, in South Africa, and the earlier study in 1970s in Nigeria showing corrosive injury was a common cause. And Buji dilation versus Sabari dilation, I think for the wave, especially in the upper esophageal, just near to upper esophageal sphincter. So if the patient had osteophytes, like old age, then Buji usually might be associated with perforation, so balloon might be considered in that case under fluoroscopic control. But in the other cases, I think Buji is better, because if we use the balloon, we need to have through the scope visualization, which will be difficult to dilate upper esophageal strictures.
Yeah.
And regarding the outcomes, there was no difference, whatever the method used, like the dilation with balloon or Buji, it's almost the same. And the other thing in our study is what the Professor Mark raised the question is like dilating without rule of 3, like dilating more than 16 millimeter versus 16, 17 to 18 and 14 to 16 millimeter. I didn't found any significant association. So overall, my final conclusion was like the technical success achieving an esophageal diameter of 40 millimeter was associated with the final clinical success outcome, and addition of intralesional steroid was associated with significant clinical outcome. Otherwise, I don't find any other factors which is associated with the final clinical success. Thank you.
Thank you.
Thank
Thank
you, Jonas,
you,
for that
Jonas.
summary.
Yeah.
Chinda, there's some interesting comments in the chat, and I'll read them out and see what. Here's one from Dr. Hopkey. First, she mentioned that. No, I'm sorry. So she's asked, can Plummer-Vinson syndrome transform into squamous cell cancer of the esophagus? I don't know the answer to that. Did you come across anything, or do you have any information about that?
Yes, I do actually, Professor Mark. And yes, so when you go through the literature, some people even believe the only reason we are still keeping Plummer-Vinson, despite the numerous criticism about the exact pathogenesis of the webs from the iron deficiency anemia, is the fact that you just cannot disregard a syndrome that is associated with an increased likelihood of malignancy. So it has been described as a potential risk factor to developing pharyngeal and upper esophageal squamous cell carcinoma.
Interesting. So then the question comes from Dr. Hala, do we need to screen for malignancy? I guess this patient's already had a thorough ENT examination and endoscopic exam. But what do you think about that?
So going through the literature about Plummer-Vinson, you see experts' recommendation, not really like guidelines, saying that all patients with Plummer-Vinson should get yearly endoscopies to assess for the potential development of an again, and the proximal esophageal squamous cell carcinoma. This patient indeed had a thorough ENT assessment that described no evidence of malignancy or any abnormality.
Interesting. Thank you. That's very informative for me anyway. There's a comment from someone else here. I think maybe it was Dahlia, that she had seen a very similar case where when she treated the web and got to the duodenum, there was the scalloped duodenum, and biopsy showed less atrophy with celiac disease. So this is fascinating to me that there could be this association.
And Dr. Sensai, about the mechanism of IDA in patients with PVS, in the esophageal stricture, the cause or the effects.
So if we are talking strictly about Plummer-Vinson syndrome, when you read through it, it is hypothesized that actually the web and potential stricture is a consequence of the iron deficiency anemia. But unfortunately, how exactly this happens, it's not clearly understood. And that's where the problem begins. How does IDA, iron deficiency anemia, result only in the proximal esophageal web? And they had postulated some things about ion-dependent oxidative enzymes that are depleted at the level of the mucosa and the smooth muscle of the esophagus. But why primarily proximal esophagus, it's unknown. And it's also clear that the dysphagia itself, when severe enough, can result in more iron deficiency anemia.
Thank you.
Okay. Yeah, Dr. Tishinda, do you have some additional slides on the case? We have
I did.
Yeah,
we
have
did,
some
but
minutes.
I think
Yeah, some minutes.
Okay.
Like 5 minutes. Yeah.
So, well, I think I'm just going to repeat a few things. So I'm going to skip through some slides that I think are not important. It was just a few notes on Plummer-Vinson for us to just be better acquainted with what this syndrome is. And basically, it is a rare condition. To make that diagnosis, you need three things: post-cricoid dysphagia, or just very proximal esophageal dysphagia, the iron deficiency anemia, and the upper esophageal webs. Now, as mentioned already, it is associated with an increased risk of pharyngeal and proximal esophageal squamous cell carcinoma. Now, it can also be called Plummer-Vinson syndrome, that is in the USA, but in the British, they primarily call it Patterson-Brown-Kelly syndrome. I'm not going to go back through the history at this time, but the bottom line is, if you're using Plummer-Vinson syndrome or Patterson-Brown-Kelly syndrome, you're basically talking about the same thing. Or if you're sick of eponyms like I often am, you can just call it sideropenic dysphagia, where sideropenic refers to the iron deficiency state. The epidemiology, it's actually more common in white females, which was surprising to me, viewing the fact that we do have more iron deficiency in Africa. And typically the females affected are between the 4th and 7th decade of life. It was very common in the 20th century in northern countries, but they've noted a steady decline over the time, and this decline is attributed to an overall improvement in nutritional status and more frequent use of iron supplementation. I came across a few cases of Plummer-Vinson in Africa, but they are basically very similar to the case we had with unexplained iron deficiency anemia. So I'll skip through those if you permit me. Now, one point I thought was really interesting was trying to understand, is PVS a myth or a reality? And the reason why people are questioning the existence of Plummer-Vinson syndrome is the fact that we have countries with more iron deficiency anemia, like countries in Sub-Saharan Africa and South Asia, but they actually have the lowest reported rates of Plummer-Vinson syndrome, according to the literature that I came across. Though some may argue that this is maybe due to poor, low reporting. People are just not reporting these cases or carrying out studies on it. But in addition to that, the pathogenesis remains speculative, and this has led to people questioning why exactly do you get Plummer-Vinson syndrome from the iron deficiency anemia. Now, we know the esophageal webs causes the dysphagia. We know there are other factors that can result in iron deficiency anemia, but how exactly does the iron deficiency anemia cause esophageal webs? That was the question. Now, they postulated a lot of things, but basically that pathogenesis is poorly understood. And there are a few things that favor PVS as a reality. And these include things like improvement in dysphagia after iron therapy and the decline that we have seen with the improvement in nutritional status and iron supplementation. And as mentioned already, you just cannot disregard a syndrome that is associated with an increased likelihood of malignancy, namely the squamous cell carcinoma. But there are a lot of things that make people wonder if PVS is a myth. And this include things like there are studies carried out, I referenced it at the end of my presentation, where they found out that there was no relationship between post-cricoid dysphagia and anemia or sideropenia. Basically, they took a population of patients with iron deficiency anemia compared with patients with not, and found out that there was no increased likelihood for them to present with post-cricoid dysphagia. In another study, they took instead patients with WEPs and compared that to patients without it, and found that they were just as likely as the rest of the population to be iron deficient. So all of this went against the Plummer-Vinson syndrome. The other thing is that the iron deficiency theory, as the etiology of the dysphagia, doesn't clearly explain why the webs in Plummer-Vinson prefer to develop at the level of the proximal esophagus, just at the level, just below the upper esophageal sphincter. And this syndrome should really be more prevalent in Africa. But then again, maybe we are just not reporting it. So this is the prevalence of the distribution of iron deficiency anemia. And as you can see, way more common in Africa and South Asia. So this whole questioning about whether or not PVS is a reality and whether or not iron deficiency is what's caused it led people to start considering other etiology to Plummer-Vinson syndrome. Is it an autoimmune phenomenon? But again, this has not been widely accepted also now. So the bottom line is the pathogenesis is just poorly understood. Clinical presentation, we talked about these already. It is the dysphagia and symptoms associated with the iron deficiency anemia. And these are just some images that shows us the possible presentation, the koilonychia, angular cheilitis associated with iron deficiency, but also different presentation of esophageal webs on endoscopy. The way we investigate Plummer-Vinson is basically the lab things to assess for anemia, the complete blood count, the iron studies, but also imaging. Here I included the barium esophagram showing a web, and also the jet phenomenon. And I insist again, our patients surprisingly had a normal barium swallow. Procedures that can be done include esophagogastroduodenoscopy, which has the advantage of being both diagnostic and therapeutic. So the treatment involves treating the iron deficiency anemia and its underlying cause, but also treatment of the dysphagia and the web. And this is where it gets interesting, because for just mild symptoms of dysphagia, iron replacement is usually sufficient. You don't need to dilate, just the iron replacements results in improvement, which favors iron deficiency really as the etiology of the whole syndrome. But for significant or persistent symptoms despite iron supplementation, then we need to proceed to the web disruption. Now, this can be done just by the passage of the scope, as reported in the literature, or preferably with bougie. And this was discussed already in the group. The proximal nature makes balloons more difficult to work with. And in our setting, balloons are just way too expensive. So we are commonly going to bougie instead. And the prognosis, again, this was mentioned already, it's really good with Plummer-Vinson syndrome. Dysphagia and anemia can easily be treated, and occasionally even you don't get a recurrence. For follow-up, it is recommended to get complete blood counts and iron studies every 3 months, initially at least, and then to get an EGD every year with the risk of developing squamous cell carcinoma. And that's all I prepared really on PVS. I ran through it a little bit fast because we were running out of time.
Thank you so much, Chinda. This was really a fantastic session. And Haile Mikhail and I are very grateful to you for bringing the case forward and for really excellent presentation and leadership of the session today. And to everyone else, I want to say we would love to be getting cases from you and for you to lead a session also, as a few of you on the call have done in the past. And Haile Mikhail and I really need this from you. So if you haven't yet presented a case here, please email us about a case you have. We've decided that unless we start to hear from more of you about presenting cases, we're going to decrease the frequency of the conference because we just don't have the engagement we're hoping for. So please email us about an interesting case you have. We'll interact with you by email, and we'd love to have more of you presenting conference as Chinda did so beautifully today. So I'm putting my email in the chat. And I know Haile Mikhail puts his email on all the emails you get from us. But yeah, you can email either or both of us. We would love to hear from you about a case you'd like to present here sometime in the coming months. Haile Mikhail, anything to add?
Yes, I think the Dr. Chinda and the team from to me from the Mibingo Baptist Hospital had been an excellent asset for the echo session. And his presentation, his history, and the way he has presented well, every step in the history, I was liking this. He put every important pointers that should be discussed in dysphagia. So this is also important for our fellows, residents who are attending this. So it's really brilliant presentation, well prepared, and it's very important for us. So such kind of team presentation from the other countries, we also encourage that. You can send us cases, we can have a slot for the presentation. And thank you, Dr. Chinda, Dr. Tumi for this program, and Dr. Chinda for the excellent presentation.
Thank you for the opportunity, really.
The other thing, I just have posted the feedback link. This is very important for us. So the feedback link so helps us to know what do you want in the future and how to improve also this echo clinic, the virtual clinic. So please fill the feedback link. It just takes 1 minute or less. And we can also get your email so that we can add you into the iEcho web platform so that you can get the presentation and the reminders easily. And if there is no any other point, our next session will be after 2 weeks, same time, Tuesday, and it's done every 2 weeks. And we'll provide CEU credit for every participant. I don't know how this CEU credit work in Cameroon or other countries, but we are providing CPD credits.
I have a quick question, sorry.
Okay.
Yeah, go for it.
This is for the team in Cameroon, totally unrelated to the case. Where in Cameroon do people get endoscopies? Is your center the only one in that, in that region of the country that performs it? That's the first question. The second question is, who performs the endoscopies? Are these gastroenterologists, internists, or are they surgeons? And then the third question is, I have more, but I'll stop at 3 because of time. At your center, is it affiliated with the cancer center? And then do you have interventional in terms of ERCP EUS? Thank you.
Well, thank you. So yes, our center here in Bingo Baptist Hospital in Cameroon has the ability to perform endoscopies. Some of the major towns, I think 4 of the major towns in Cameroon also have the ability to do that. And in other towns in Cameroon, it's done by gastroenterologists primarily, but in Bingo Baptist Hospital, it's done by internists. So Dr. Tumi here and myself and a few other internists are responsible for endoscopies here. Our ability to carry out advanced modalities like ERCP, not yet. We are not yet able to do that in the entire country, actually. So basically minor stuff. We do banding, we do dilatations a lot, but ERCP, MRCP, not yet. We are not there yet.
So can you probably agree and ask also if you can share us any publications that could help us to know the endoscopic capacity or publications related to that from Cameroon or from your Bingo Baptist Hospital? I think that will be also good for us.
Okay, we'll do that. We'll do that.
Okay. Okay, so Professor Mark, any other points? So we are already over time.
I think we're ready to sign off. Thank you everyone for tuning in and participating in this great session.
Yeah, thank you all, especially Dr. Tichinda and Dr. Tumi today. Dr. Tichinda, you did a great job and thank you for that.
Well, thank you. Thank you for the opportunity. And thank you to Professor Mark, really. He's the one who taught us endoscopy, and now we are here discussing it with him. So it's a pleasure.
Wow, that's great.
Thank you.
All right, we'll see you all in 2 weeks.